has devoted all his life to keyhole. It all started in Sydney, Australia, where he completed his early training in medicine, and thereafter he worked with Professor Yasser as well as in US. After his initial work in US, he shifted his base to Prince of Wales Hospital, Randwick, Sydney, where he is still working. He has been running his lab as well and dedicating a lot of work in keyhole neurosurgery, as well as a lot of research into brain tumor. So, sir, it's a great honor for you to have spared time. I would now like you to please take the screen and share your thoughts on your topic, sir.
Well, thank you very much, Ashish, for that lovely introduction. It's a great honour and a pleasure to be here amongst great leaders of neurosurgery in India. And I would consider you all good friends, and it's great to be together again. Look, my job here, I guess, is to do a brief introduction to this whole topic of using the endoscope to enhance the surgical resection of deep-seated supratentorial interaxial tumours. The concept is easy. Please don't think that it's complicated. When I first started neurosurgery, we were taught to use dental mirrors to look around corners, because indeed it was very clear that the loops, the microscope, and direct vision, of course, only gives you a very coned, limited view. And if lesions are not perfectly cylindrical, and they aren't, they often have multiple axes, then of course you have to look around corners to achieve what you believe should be a maximal resection. So those of you who are old enough to remember the use of dental mirrors, they were terrible. You'd put them into the operative field and they'd fog up. You could barely see anything anyway. And we didn't even have angled instruments in those days. The endoscope increased the illumination down those narrow corridors, and then, of course, using angled endoscopes allowed you to look around corners. It wasn't good enough looking around corners without being able to operate around corners, and thankfully, over the last decade, many of the instrument companies have developed angled tools, mostly angled bipolars, but also angled suckers, angled scissors, angled grabbing forceps, to allow us to then utilize this angled view. When do you need the endoscope? Well, like I said, the whole long axis concept or philosophy is good if you have a perfectly cylindrical tumour. But if you don't have a perfectly cylindrical tumour and there are multiple axes to a particular tumour, then following one long axis isn't good enough. You have to then look around corners to achieve that GTR, gross total resection. Sometimes you do have perfectly cylindrical tumours like this one, but if you looked at the long axis of this insular glioma, of course, it's going to take you through eloquent brain. You can't do that, so you're forced to operate along the non-long axis, the short axis, the transsylvian approach. The transsylvian approach will give you great visualization of what is directly underneath the sylvian fissure, but it doesn't give you good visualization of the tumour that is under the very sensitive and eloquent opercula. And then, of course, we're not going to discuss infratentorial tumours today, but with infratentorial tumours, to get access to them, it's often through very, very crowded corridors, such as this corridor, to achieve a resection of that midbrain glioma. We would have to operate through the opticochoroidal window. It's a very limited window. It doesn't allow light in, and that's where the endoscope becomes an invaluable tool to bring light to the target. So these are the helpful tools that I think you should have when it comes to endoscopic assisted resection of deep-seated supratentorial tumours. I think any sort of brain mapping technique, so you're not going through eloquent cortex, is good, or actually essential. Frameless stereotactic guidance allows you to make your craniotomy more targeted or more localized, and it's therefore smaller. I'm sure you've all heard me talk about these fat bipolars, and these fat bipolars I think are crucial with glioma surgery because they allow the glioma to melt rather than char, and brain will always char. So it does help you differentiate tumour from normal brain. And then, of course, like I said, angled instrumentation. An endoscope, any endoscope can do. I like endoscopes with an offset handle, and that way it doesn't hit the microscope. And I like it when the shaft is robust and you can hold it by the shaft and it doesn't crack. I really like these hybrid instruments, and what these allow you to do is to be a three-handed surgeon, I guess, because you can hold the scope in one hand, and then you can hold this instrument, which is a hybrid instrument, in the other hand. And this allows you to have suction and the bipolar all in one instrument. This is an example of a bad surgery by me. I can remember this case vividly. We did a nice small keyhole craniotomy of the Sylvian fissure. I got a very good resection of the infratemporal portion, the temporal portion through the temporal stem. I actually got a pretty good resection of this part of the tumour, but look what I've left behind. And I remember asking for the endoscope, and the nurses couldn't find it, so I said, "Oh, look, don't worry." But if I'd only put the endoscope in there, I could have used it to angle my view upwards and achieve a more complete resection. This is a case where I did use the endoscope, and you can see it's a very big tumour. The long axis looks kind of like AP back here. But then again, if you just did this approach, the AP approach, you'd miss this sort of portion out here. In other words, like I said previously, multiple axes in one tumour. And by using the endoscope, I managed to achieve a complete and radical resection of that tumour with a small keyhole craniotomy and a good outcome. I really like showing this case because it demonstrates what happens when you use all those tools and put them all into one. Ashish, I forgot to look at my clock. So Ashish, can you make sure that you give me a 5-minute warning at 15 minutes? So look at this tumour. If you do an interhemispheric approach to this on the ipsilateral side, it doesn't give you good exposure to the most lateral portion. So a lot of people do a contralateral approach, transfalcine, to this tumour, and that's very reasonable. But if you use all those tools I talked about, firstly, MRI scanning and making sure that you can tell the structural anatomy of this case, you'll see that there's some pretty large bridging veins on the other side. So that's already a bit of a red flag to going contralateral. And then if you use omniscient quicktome, you'll see that there's a lot of very eloquent parcellations on that side and not so eloquent parcellations on this side. So by using all those tools, what we're going to do is an ipsilateral approach using angled view to get out to the most lateral portion of this interhemispheric tumour. And again, time is of the essence, so if you don't mind, I'm not going to go through this whole video, but I want to show you, this is normal standard microsurgical technique. And we take out as much as we can using the microscope, and then we place the endoscope in. Again, it's a very simple principle. The principle being is that you want to look underneath that eloquent cortex. You don't want to retract the brain too much. You want to create a cavity first into which you then put the endoscope, and then you use a selection of tools to work outwards. Now, again, at this stage, I'd like to underscore the beauty of the endoscope in improving illumination, clearly. And not only that, it improves visualization. Now, a lot of people think, oh, the endoscope, it takes away your ability to see 3D and you can't see the anatomy as well. But in fact, it's exactly the opposite. If you want to magnify, you just go closer to the target with your endoscope. If you want to get a more big picture, you pan out. And if you want to use different angles, you can. There's 30, 45, and 70-degree angled endoscopes. So you can use a variety of endoscopes to look more angled. And this hybrid instrument I'm using here can be angled as well. It's malleable, disposable, and you can bend this as much as you like so that you can get all the way out and get this tumour out completely. And then after surgery, you can see the incision I made, quite a large incision because I didn't want to sacrifice any bridging veins. And just in case there was a bridging vein right in the middle, I thought it best to do a long incision. And you can see that we've got a complete and radical resection all the way out laterally and no footprints. So no damage to the overlying cortex, because we came in from this angle here into hemispheric and looked outwards using the endoscope to get the complete resection laterally. Just to identify a few other tumours where these principles can be used. Insular gliomas. Now, why insular glioma is difficult? Because you're operating underneath a operculum. So this part here, easy, because trans-sylvian or transopercular, you can get this part easily. But this part back here is very difficult to get unless you have angled visualization. Butterfly gliomas, why are they difficult? Because it's, again, ipsilateral, fine, but contralateral, you know, we know now that the cingulum is an incredibly important structure. And let me just teach you a few lessons. When I first started doing butterfly gliomas, I used to go, oh, hang on, I can just go above the pericallosal through the cingulate gyrus on the other side. Don't ever do that. That's when you're going to have a lot of problems. You can damage one cingulate gyrus, or the tumour can, but if you damage the other cingulate gyrus, in other words, if you try and cut corners and not use an endoscope to look under the pericallosal and you go over the pericallosal, you'll get a lot of problems. Please learn from my mistakes. Microscope ipsilateral, endoscope into the cavity, look underneath the pericallosal and don't breach the contralateral cingulum. Thalamic gliomas, they pose a huge problem to all of us because they're so deep and surrounded by such eloquent tissue. The last thing you want is to be operating in the dark with a thalamic glioma. And that's where the endoscope really becomes a valuable tool. Not so much because it can give you angled views, but because it really does improve the illumination down this deep, dark corridor. This is a video of an insular glioma. Ashish, are you keeping an eye on the time?
Please carry on. Please carry on. Time is okay.
How many minutes have I got? Another 10 minutes, do you think? Or 5?
And then carry on. We'll tell you. We'll give you a hint.
Okay. So insular gliomas, I've already discussed that, and there we are through a mini pterional, splitting the sylvian fissure, and then just placing the endoscope into that cavity so that you can do this sort of procedure where you can go trans-sylvian and get a complete resection without damaging the overlying operculum. Butterfly gliomas, again, I can't stress the importance of basic surgical tenets. And with butterfly gliomas, one of the most important things is early identification of the fornices before you start attacking the other side. So I think that's really important. Look at this butterfly glioma. Look how close the fornices are to this tumour, here and here. So the first thing I do with a microscope is make sure I identify the fornices, preserve them. And once that's done, then of course you can start with the other bulk of the lesion, taking out the tumour from the ipsilateral side and the contralateral side using the endoscope. So please, the basic surgical butterfly glioma. And then for the contralateral portion, this is what we do. We've created a cavity, we put the endoscope into that cavity, we go under the pericallosal, under the corpus callosum, do not damage the contralateral cingulate to get at this portion on the other side with angled visualization. It can be used for both butterfly gliomas, anterior and posterior, of the splenium or of the rostrum. And again, here's the principle. Microscope, ipsilateral, endoscope, contralateral. Small incision, complete excision, good outcome. Here's a recurrent one. And this is what I'm talking about. We're on the right side looking over to the left side. This is the pericallosal. We don't want to go above the pericallosal, even though it's tempting to, and even though it would be a whole lot easier to go through the cingulum, through the cingulate gyrus on the contralateral side. Don't be tempted. So maintain the integrity of the pericallosal, maintain the integrity of the contralateral cingulum, and work under this structure using angled visualization and angled. So here's my pointer just to see where I am. And I'm over the other side. I'm using angled bipolars. I'm not stretching the pericallosal too badly. I'm now using this angled sucker. I've got angled visualization, and look how nice you can see the anatomy. So please don't think that the anatomy is any more obscure. It's actually clearer. And it's just as easy to identify the brain tumor interface using the endoscope as it is with the microscope. And again, you can see how we've reached across and got a complete resection of the contralateral portion. We haven't stretched any tissue, and we certainly haven't damaged the contralateral cingulum. Just to show how it's worthwhile, we've just published a paper, had it accepted by Journal of Neurooncology, showing that with radical resection of butterfly gliomas, including the contralateral portion, you can improve the prognosis of butterfly gliomas to that of any other glioma, i.e. from 6 months to 18 months. So it is well worthwhile doing a complete resection of these lesions. Sometimes the endoscope can't reach that far around corners. So if we're coming down here on this, there is no way my instruments are going to be long enough to get all the way up to here. And sometimes you just have to understand the limitations of endoscopic surgery. In this situation, I did bilateral craniotomies and came in from 2 different axes. There was no way I could have done it from one side. And you can see both sides, minimal invasive, and this patient had no neurological deficits after this operation. Thalamic gliomas, I know a lot of you are talking about them today, so please, I won't steal your thunder. Simply to say they are deep, they're difficult, there's a lot of eloquent brain around, and there's no better tumour in which you need good visualisation, good illumination, and angled views than a thalamic glioma. They are just so deep and so nasty. Here's one that we did. We came from the contralateral side. Why? Because there was a bit of a tumour, is a multifocal GBM, and you can see that there was a long axis. So it was pretty obvious that we had to come from the contralateral side. A complete resection, good outcome. Here's another thalamic glioma. And again, there's many different approaches, as you know. Interhemispheric, transclosal, transventricular, interhemispheric, transventricular, transthird ventricular, trans-sylvian, and transcortical. This one, I'm not quite sure how we did this one. Through the superior parietal lobule. No, maybe from the contralateral side. Yep. Contralateral, transfalcine, transcallosal, transventricular. And again, look how we've contralateral, small craniotomy, interhemispheric, subfalcine, transcallosal, transventricular, reaching all the way out laterally because we came from the contralateral side. Again, please, I can't underscore the importance of the long axis more than with these deep-seated tumours. You've got to look for the long axis, and look at it here. It's beautiful. Long axis here takes us through a very small bit of normal brain, transsulcal, superior parietal lobule. And I could have easily just looked at one of these other views and gone trans-sylvian. It wouldn't have been as good. Or transcortical. It wouldn't have been as good. And again, position the patient so you don't need retractors. I know a lot of you are tempted to use tubular retractors and self-retaining retractors, and I don't blame you, because with these deep lesions, the brain does tend to fall in and you lose your visualization by crowding of the corridor. You won't do that if you do proper positioning. And what I mean by proper positioning is that you're always operating perpendicular in all 3 axes. X, Y, and Z. All 3 axes, you're operating perpendicular so that the brain doesn't fall into that corridor. Here's the patient's biopsy. Here's our small craniotomy. Here's our transsulcal small corticectomy. And again, one of the other reasons I don't like using retractors is because I like using the natural elasticity of the brain, the natural movement of the brain, so that you can look around corners, you can get good visualization. Look how I'm moving all the time. You're always moving. You're using the natural mobility of the brain. Now, I know Dr. Yadav is going to talk to you about tubular retractors. Well, he's got a great tubular retractor that he's invented himself, and it's not fixed. And I really like that. So if you're going to use a tubular retractor, make sure you use his, because anything that's fixed, you're going to stop yourself from moving or using the movement of the brain. If it's not fixed, it can be a whole lot more effective, and it doesn't impede your natural movement. And again, that brings us to the end. Good outcome. So in conclusion, I'd like to say that, without sounding like a broken record, I don't think we need to talk about the importance of complete resection anymore. The literature is clear. The guidelines are clear. Across the world, we're all saying it. And if you look at the literature, it's very clear now. You do have to get as gross a total resection as possible to confer a survival advantage for your patients. It's no longer controversial. And that's for all grades of tumours. It's better to get it all out. And that's why it's so important to use the endoscope, because the endoscope allows you to get it all out. You've got to do thorough preoperative planning so you can pick the long axis by the 2-point rule. You've got to utilise technologies such as frameless stereotactic guidance, high magnification. You try and preserve all the en passant vessels, and endoscopy. Endoscopy improves the surgeon's ability to achieve this GTR by decreasing the amount of collateral damage, in other words, keyhole, improving visualization by improving magnification and illumination, enabling the surgeon to look around corners under eloquent brain, and it actually helps to define the brain-tumor interface. Thank you.
Thank you, Dr. Teo, for the elegant lecture, and then we will have the discussion at the end of all the lectures. Dr. Swami, can you please invite the next speaker, please?
Yeah, certainly. No. Just a minute. The next.
So yeah, the
next speaker is Professor Yadav.
Yeah.
I'm sorry. Can I interrupt?
Yes,
Manas, sir?
yes.
Sir, it would be really very late in Australia, so I don't know whether Professor Teo would be staying back with us. It would be around 11 or 12 there.
Okay.
So I'm not sure. If he's staying back, that's fine. If he wants to take the question.
We can take his questions.
I'm very interested to hear some of the talks. So I'm going to try and stay awake. Now, if at the end you call me to say something and I'm asleep, then I apologise. But I'm going to try and stay awake to listen to the other talks. They all look very interesting.
Oh, okay. Great. Great.
Thank you.
Thank you.
Yeah, the next speaker is none other than Professor Yadav, who has revolutionized endoscopy, at least, and he has been a father figure. As Professor Teo has said, he has devised many cheaper devices, and then almost all the places in the brain, whether parenchymal, intraventricular, he has mastered that. Okay, I will not waste much this thing. His national importance, Dr. Yadav, sir. Please continue, sir.
Thank you very much, Professor Swami, Professor Charlie, and the Neuroendoscopy Society of India for giving me this opportunity to discuss the endoscopic removal of deep-seated brain tumor using tubular retractor. So there is nothing to declare except that we devise a tubular retractor, but I do not market it. It is available free of cost. We all know that deep-seated intraparenchymal or intraventricular tumors are difficult to remove. There is a difficulty in visualization, as Professor Charlie has already said, but this can be done with the microscope or endoscope. To visualize at the corner, you need help of endoscope, which has been discussed. So the difficulty, especially for deep-seated lesions, whether it is parenchymal or intraventricular, is there is difficulty in maintaining the corridor. But as Professor Charlie has said, that the best, skilled neurosurgeon do not need any retractor. It is a fact and this is the best thing. And the best thing, which has already he told, that your incision has to be not only at the highest point, but you should be at right angle to the floor, so that so you need to tilt the table in such a way that the lesion is 90 degree and there is no brain fall. So in that case, most people who are excellent neurosurgeons do not need retractor its effect. But for deep-seated lesions, there are difficulty obviously for ordinary neurosurgeons to maintain the corridor. There is a risk of injury to the overlying brain when you introduce and take out the instrument, especially if there's the long-standing, long surgery. There may be poor visualization if there is a bleeding, maybe difficulty in control of hemorrhage, and the large and vascular lesions may be difficult to treat, deep-seated lesions. And we keep on talking endoscope, endoscope, endoscope. So everything is not so good. Especially when you use endoscope, you must have seen that Professor Charlie has initially used microscope for straight work because that is the best thing one can do. And so you need cavity, and there are other limitations of endoscopic surgery. Principally, the pure endoscopy could be divided into two. One is the channel endoscopic surgery, where the examples are ETV and most of the intraventricular surgery, where it is a pure endoscopy surgery. The instruments are passed through the working channel. But since you pass instrument through the working channel, so there is a difficulty in biomanual dissection. It is done under liquid and air media. Most of us use liquid media. So if there is a small little bleeding, then there is a difficulty in control of bleeding because you cannot see anything. So difficulty in control of hemorrhage, especially if there is a severe bleeding. So therefore, because of these two difficulty in biomanual dissection and difficulty to control hemorrhage, it is indicated, channel endoscopic surgery is indicated only when you have a small lesions and avascular lesions like colloid cyst or arachnoid cyst, something like that. And you need a specially designed instrument because you have to pass it through the working channel. And obviously there's a small opening. So there are some limitations of channel endoscopy which can be overcome by using a tubular retractor or port system. So using an endoscope and using tubular retractor, you can overcome some of the difficulties of endoscopic surgery, and those are, it is also a pure endoscopic surgery. The instruments are passed by the side of the endoscope. There is no difficulty in manipulation of the instrument. So there is an easy biomanual dissection. It can be done in air or liquid media. Most of the time, it is the air media. So you can watch from exactly from where the bleeding is coming. There is no difficulty in controlling even the severe bleeding. So large and vascular lesions can be operated, and you can use routine instruments in these cases. These are the example of channel endoscopic surgery in which you have to pass instrument through the working channel only. Whereas in port system, the endoscope is stationed at one end and then you pass instrument by the side. So combination of endoscope and tubular retractor can overcome the limitations of channel endoscopic surgery. There are, if you have to use retractor, it is better to use tubular retractor rather than Lila retractor because that exerts localized pressure. The tubular retractor exert low pressure to the surrounding tissue, and especially if your tubular retractor is very soft, like if it is of silicone material. So the low pressure is because the pressure is distributed in all the direction rather than at localized this thing. Although there are many tubular retractors are available, but they have some limitations, and especially the greatest limitation when you are working in a small place is the high cost. They are rigid in nature, so therefore some of them are rigid, so they produce trauma to the surrounding brain, and they need comparatively large opening because of their size, usually around 2 centimeters in diameter, to reach the site of interest. And majority of them, they require a holder, so there is a time wastage in locking and unlocking when you move it to the different directions. So this is a great limitations. There is an opaque wall, comparatively heavier, as against our tubular retractor, which is very soft. And another unique nature is that which has come after the longitudinal cut. If you don't have unique, initially I used to use it without a longitudinal cut, but then I used to struggle to make it small to introduce through the smaller opening. But once I made a longitudinal cut on this, then you can fold this retractor and put it through a smaller opening. And since it is a very soft, so even the brain, when there is a tight brain, it collapses. So it does not cause any injury to the brain. And it protects brain. Not only that, it protects brain, especially when you use endoscope, it protects endoscope from soiling the lens tip. So using tubular retractor gives you so many advantages. It is inexpensive, simple, helps in stopping bleeding. One advantage I found of this retractor is if there's a bleeding, then you gently push it down, and because of tamponade defect, the bleeding stops. It is effective and safe. It requires a small brain opening. It is soft, so there is no retractor-induced trauma. Protects brain from instruments, and otherwise light-weighted, can be moved in any direction without any holder. It's a transparent, sorry, so you can visualize things all around. The Professor Charlie already told you the basic things. I mean, I'll not be covering everything. So one can use image guidance, which is the best thing. But unfortunately, I think most of us do not realize working in a place where you don't have any facilities. So what we did was we localized the tumor, thalamic tumor. At the center of the lesion, we use the Evion capsule, and we localize the tumor, center of the tumor, where the tumor is lying. So we identified the center of the tumor, and we can, start thinking you can have the, the incision from wherever site you want. For this thalamic tumor, obviously we took a high parietal approach. So then you decide the things accordingly, whichever is appropriate for that tumor, taking into account of a long axis also. Regarding the technique, make a small craniotomy or an enlarged burr hole, and then put the nasal speculum in a closed limb position. You can use microscope for sulcal dissection, but later on use this nasal speculum in a closed limb position. and then gently enlarge it, put the tubular retractor inside, take out the nasal speculum, and then this is the final picture. And after that, you can use either a microscope or endoscope. So surgery can be done with either endoscope or microscope or even exoscope. I use 30 centimeter long scope, which is 4 millimeter in size, 0 degree or 30 degree or 70 degree, depending upon the visualization which you need. And I use endoscope holder so that both ends are free. This is a short video just to give you idea about how it is to be used. This was one of the case, thalamic tumor. So we use high parietal transcortical approach, dural opening, small dural opening, pile stitch. So in the initial period of my use of tubular retractor, I found that large tumor, if you have the cortex tend to fall, not because of the positioning, but because you enter in the ventricle, or if the tumor is very big, the parenchyma fall away from the dura. So to prevent this, the brain parenchyma falling away from dura, we started using this pile stitch, the tubular retractor being put inside. And in this case, we could not use navigation because we did not have. Now we have a navigation, so now we use navigation. And once you reach there, you can use both your hands and use common instruments, dissect the tumor from the normal structures using the standard microsurgical technique. And I think in the interest of time, I fast forward this and debulk the tumor and do surgery. So all around you try to do the standard microsurgery, and in the end, after good hemostasis, you should close this. So the result, we have used this tubular retractor in more than 800 cases of hematomas, deep-seated tumors. Some of them, around 250, were the deep-seated parenchymal or intraventricular tumors. Majority underwent gross total excision and near total excision. The average blood loss or operative time was quite less. The complication included some small contusions, transient hemiparesis, speech deficit also, but these were temporary. So it was safe and effective. And there were other authors also who used tubular retractor, a combination of tubular retractor and endoscope, and they found that the results were quite satisfactory. One of our case, initial case, but we use microscope in this pre-operative and post-operative. Another case, good decompression, intraventricular lesion, total excision. This was a tumor which was there in the lateral ventricle and third ventricle, good excision. I think in the interest of time, this was atrial tumor, which was also totally excised. So introduction of tubular retractor, and then piecemeal excision of the tumor. And then in the end, taking out tumor in piecemeal and then perfect hemostasis at the end, and put in a EVD in the end, another piece, and then hemostasis. So, but there are limitations. There could be migration of the tube, especially the instruments are bulky. So we started using sutures at the outer end of the tubular retractor, and fix it with the drapes. So once we started using sutures, that problem of going it down, either migrating deep or coming it out, also has been solved. So you keep on finding problems and find solution. There may be brain injury in pushing the tube deep after the partial withdrawal. Retractor may become unstable when the tumor is very large. This is a problem which we come across, and after that we started using a pile suture. Brain may fall. There's a learning curve, difficulty to remove the superficial part of the tumor. So for superficial part, obviously don't use tubular retractor. You can take out the tubular retractor and do surgery without this. There may be difficulty to significantly change the direction. So it has to be, the tubular retractor has to be about 90 degree to the floor. So same principle of surgery. You for detail, you can see these two chapters in my book, Neuroendoscopic Surgery, A Comprehensive Approach. To conclude, surgery for deep-seated and parenchymal and intraventricular tumor using endoscope and tubular retractor is safe and effective. It can be done when you have a large and vascular lesions. One can control bleeding very well, and good bimanual dissection is possible, but there is a learning curve. Thank you very much. Thank you.
Thank you, sir. Thank you. It's always a delight to hear to your lecture. So elaborately explain how to use the tubular retractor, how to develop it, how to make it cut, and in a dramatic way introduce it, and how to operate in a deep set and then its limitations. We really thank you. We'll keep the discussions at the end. May I ask my co-hosts to invite the next speaker, please?
Please invite the next person. No, that's fine. Professor Swami, please invite Dr.
Okay.
Next Pathak, I think.
So the next speaker is Professor Pathak. Sir, welcome you, sir. Sir was my professor who taught me neurosurgery and held my hand, make me learn all the surgery, whatever I have learned till now. And sir was in PGH Chandigarh, a stalwart. He has had a short tenure in England too. For 5 years, he stayed over there. Right now, he is working in Fortis Mohali. Sir has developed interest in endoscope and has done very well in endoscope. And then he is there in all the national webinars, and without wasting much time, I'll invite Sir to give his oration, please. Professor Pathak.
Yeah, I'm trying to share my screen. I'm just trying to share my screen. Am I visible?
Yeah.
Okay. Right. Okay. Thank you very much, Narayana Swami. It was so kind of you to talk so much about me. I don't think I deserve all that. But anyway, the first two talks had made my life much easier. So I'll just deal with the same topic, but this is pure endoscopic now. Professor Charlie Tew was really very eloquent in what he really described, combination of both at times, which is definitely done in many cases. But I'm going to talk purely on pure endoscopic parenchymal tuber excision, which is a challenge at times. Now, I have no disclosures. I'll start with a very naive question of why we need the endoscope. Is it a fancy? Is it a fashion? Is it a show off? The question is none of these actually. Because we know that microscopic excision is a time-tested phenomenon, and it is perceived to be better because there are availability of high-end microscopes, advanced MRI sequences, support of neuronavigation. But when we come to compare the advantages and drawbacks of microscopic excision, we know that majority of these surgeons are accustomed to the technology, so they feel it's easy, comfortable. Precision is good actually nowadays, and surgeons can use both hands, which obviously has now been eliminated in endoscope. But the drawbacks, as we have already discussed, is that illumination is lost at the depth, precision is compromised, vision is along the long axis of the beam, and the corners are always compromised. So we need more retraction to look at the corners. So that's a problem. But when you come to endoscope, we have a lot of advantages because the source is near, the magnification is good, can help you looking at the sides, using angled scopes, retraction therefore becomes limited. And of course, there's minimal invasiveness in the corridor. But of course, you have got fogging, blood staining, difficult to visualize in bloody fields, and there's a steep learning curve, as it has already been pointed out by the previous author. So that's the principal difference of visualization in both the equipments. Now let's think from the neurosurgeon's perspective. A neurosurgeon would like a better view of inside of the lesion, a higher magnification illumination, and of course, high quality images in the narrow fields. The patient obviously wants that smaller incision, less pain, shorter operating time, shorter hospital stay, faster recovery, early return to normalcy. So there has to be a balance between the two. Till the past decade, neuroendoscopy was mostly used for pineal region tumors, pituitary tumors, rat case cleft cyst, skull-based tumors, ventricular tumors. So for parenchymal tuber excision, so what are the objectives? We have to look for minimal invasiveness, precision, minimal distortion to the anatomy, quicker recovery, shorter hospital stay, and less financial implications. So if that is so, why endoscopic parenchymal tuber excision is not routinely practiced? Because I think it's because it's unfamiliar technique to still many of the surgeons or most of the surgeons. There's a steep learning curve and there's the apprehension of incomplete excision of deep-seated lesions. So for the juniors who are attending this webinar, I would just go quickly through the different stages as I would divide it, because I believe there will be quite a few juniors who will attend this. So the planning step number one is you need to have a good contrast MRI under a neuronavigation protocol. There's a standard and a neuroanesthetic induction. You fix the head, or nowadays with the, you can even not fix the head. The navigation systems are a different kind. We have got a navigation system where you fix the head. It's a stealth one. And then you confirm the position of the tumor and the center of the tumor where you need to go and operate. Step two is the entry and resection. So you open the dura in a cruciate fashion. The corticectomy and corticotomy site is decided based on the neuronavigation guidance depending on the shortest route of entry. It's not always true that you go to the shortest route of entry. You have to see the eloquence of the structures and the disposition of the tracts as per of DTI imaging. That's very, very helpful, I tell you. Corticosectomy and corticotomy size has to be, again, optimal for enough space for introduction of the endoscope. And at the same time, under navigation guidance, the lesions is reached at the depth by gradual dissection. So this is, the DTI. You see, if the lesion is here, and you can very well see how this is the exact approach where you can go into this lesion without damaging the fibers of vision. So that's where you need to look into how the fibers have been splayed. Step 3 is initial debulking using a zero scope. And then at the same time, you hold it on an endoscope holder. So there's bimanual freedom. Subsequently, a 30-degree scope and very rarely a 45-degree scope is required to go to the blind corners. Usually, there is no need to have higher angulation in these scopes. The tumor excision follows the rules of cautery, suction, and CUSA, and the retraction is simple. It can be single, twin blade, and tumor retractors. I'll dwell with this later on. This last stage is, of course, damage avoidance and closure. So initial corticotomy margins, which are not supported, that led to subpile hemorrhage and cortical changes. So we have changed onto a glove strip technique, which circumvents this issue. Hemostasis is achieved in the usual manner, and there's complete dural closure after that. Now I'll just take you through some of the cases. So this is as you can see, a DTI image where you can see there's a lesion here. Now we managed to enter into the lesion. So this is where you just enter into the tumor, and as you enter the tumor, you know that you are in the lesion there. Soon after that, once you've entered in the lesion, you suck away the central necrotic area. So you create a space, and as you can see, as you create a space, you don't need any tubular retractor or any other thing. Might be the lip can be just supported with a single blade retract in a very gentle manner. So this is a deep-seated tumor, mind you, we are talking about. And then, of course, as you can see here, just with a single retraction, the tumor is, you go around the corners of the tumor and try to separate out from the surrounding tissue. And as you go around, you just keep small patty, and that itself acts as a support. So you don't need anything. And that's, you see that the edematous brain is coming into view as you're going through and through around the corners. And of course, you go to the last stage, you go to the brain tumor interface, where you know that you have visibly, you have removed all what looks to be a tumor to you, and that's what it is. So this is exactly what we do. And we put a patty on the margin of the corner where you go into the lesion. And of course, the margins are supported by just glove strips. So that's what we do. A single retractor is good enough to hold. And sometimes, as Professor Charlie showed, that we don't need two retractors also. As you can see, this is a glove which is supporting the edge. And there's a large tumor actually going right into the depth of the brain. And as you can see, with both hands, you can keep on sort of operating upon it. And that's how you can gradually remove the whole thing. And at the end, as you can see, the tumor itself, this is the gloves you can see, which is holding the cortical margin. So there's no subpile bleeding. And just in the simple way as you do, you keep on removing this tumor, and gradually the tumor shells out by itself. And at the end, you have reached the interface between the tumor and the normal brain tissue, and that's the end of the surgery. Near total excision is possible in most of the cases. As you go to the depth, you gradually get hold of the tumor, you position the patient in such a way that a very mild retraction is good enough to get to the tumor. And no matter how big the tumor is, solid tumors are rather fun actually. You can gently even retract within the tumor margin first, and then get to the whole tumor and remove it. So that's how gradually this is a very firm tumor. It was not possible to remove with CUSA, so you just keep on removing it, and at the end of the day, you are successful in removing the tumor completely. So that's what we have achieved. What about surface lesions? People might laugh. Why do you want to remove surface lesion endoscope? Now, this is through the endoscope sheath, through a 2 centimeter craniotomy. You've gone to a surface lesion, which is seen very well. So what you can do is that follow the same principles. First, enter into the lesion, remove it, and then gradually you go around the tumor and brain interface, and this can be removed completely. So that is quite possible. So this is the same patient. You see the small craniotomy through which we entered. You removed most of it, and this patient, the surgical time was 1 hour 50 minutes. Blood loss was normal. Clarity, illumination, magnification was very good. No hematoma bleeding problems. Craniotomy was a mini one, and patient was problem free. And this is another patient. Of course, this is a posterior fossa tumor. This is supposed to be a talk on supratentorial, but I just couldn't help. These are fun actually to use an endoscope in these cases. You make a small opening, and there you enter and evacuate. This was a hemangioblastoma, so you evacuate the fluid. Moment the fluid is evacuated, just one single retractor, your main attempt is to remove the mural nodule, and that's what we are aiming at. And so once you reach the depth, you can see the mural nodule, which you tease it out, and then gradually you separate it from surrounding brain tissue. And once the mural nodule is separated, you get to the pedicle, which was feeding this mural nodule. And once this is there, you coagulate that pedicle. And once you have removed the mural nodule, you just have a good look all around to see there's no blood clot or anything sticking around, and that's very easily removed. So that's real fun. So this one just took 1 hour, 50 minutes. Blood loss was normal. And all those clarity, illumination, magnification was very good. No hematoma, advantage of good view all around, and craniotomy size was 2.5 centimeters. Now, this was a challenge. This is a 27-year-old female who presented with seizures. There's a large tumor which is going right deep into the thalamic area. This is calcified. So question is, and it's infiltrative. You can see it's diffuse. It's not well localized. When it's well localized, you can make the margins very clearly. Now, once we entered into this, we realized that this is so hard and calcified that no matter whatever you use a suction, you use a CUSA. Here, I had to use 2 retractor blades. And then, of course, you keep on removing it. As you can see, suction was not helping, CUSA did not help. So we just use rongers. And that's how, once you debulk the calcified bit, you could see how hard and tough it is stuck to the surrounding brain. So like a normal dissection in a microscope, you have to do this. I won't recommend this for beginners to start with, but yes, and gradually at the end of the day, you have a good tumor interface. You coagulate the margins, you put all the hemostatic agents, and that's the end of the surgery. So this was this lady who, as you can see, we have gone right up to the level of the ventricles and the thalamic area, removed most of the tumors, I think so. And she had this was oligodendroglioma, which was given radiotherapy because it was grade 3. Surgical time was 2 hours, 15 minutes. Blood loss was normal. Clarity, illumination, magnification, very good. The advantage was a good view all around, and the craniotomy size was 40% of a microscopic exposure. So this is the lady after receiving the adjuvant therapy, and she's doing extremely well. This is another interesting case, a 25-year-old female who presented with seizures. Biopsy was done by some other neurosurgeon in another city, and they said it is low-grade glioma, nothing to be done. And in my opinion, this is a high-risk low-grade glioma. One should have gone for total excision. But whatever it is, she presented with recurrent seizures, and obviously we went for total excision of this using an endoscope. It took a little bit of time because she developed some bradycardia in between when we were on the medial aspect of the tumor. The surgical time was 3 hours, 25 minutes. Blood loss was minimal. And again, all the parameters were so good. She had standard craniotomy, so obviously the craniotomy size was the same as before. And of course, she remained problem-free and was discharged just within 2 days' time. So the points to consider when you compare the 2 neurosurgical techniques, this is for the younger neurosurgeons who are attending. Surgical time, illumination and clarity, magnification, blood loss, craniotomy size, tumor bed hematoma, extent of excision, outcome, and the complications that you have. And the biggest question that you ask, is it safe? Any new technique you think you want to embark upon, you must be sure that it is safe. And we published this, based on these points, published this article for the beginners, which clearly showed that endoscope does have advantage. Now, this is a comparison of various series that we went through the literature, and we have Joe there, Plaha there, Kasam there, and our series also. Plaha has got a good series which is published. We had pure endoscopic cases of 22. Endoscopy assisted, there are plenty. We don't count them as pure endoscopic. And we could achieve gross total excision in 19 and subtotal excision in 3. I would come to now a controversial topic, because a lot is talked about tubular retraction, and it is claimed that tubular retraction definitely gives minimal damage to the brain. Now, tubular retractor system can be foldable or unfoldable. Thin self-rotating retractor blades can also be used. And there are plenty of articles which talk of various tubular retractor systems. Some were very expensive, some are very cheap. As Dr. Yadav said, he gives them free of cost. So question is how to enter a deep-seated lesion in the brain. Normal brain retractors do not apply even as it claimed, do not apply evenly distributed pressure. Hence, it is claimed that the tubular retractors give a evenly distributed pressure. And as it is claimed, it offers advantage for low retraction pressure. And serial dilatation techniques have been used by many authors to enter into the deep-seated lesions. So question is there a scientific basis of what has been claimed? We have got articles which says they have used tubular retractions along with spatula to get into deep-seated lesions, and they can only, when they use the spatula, they can use into the defined working space. Just a tubular retractor might have difficulty of to rock the retractor. You cannot see the sides through the tip. And this is the study of its kind, which says restricted diffusion on DWI as markers of the brain, cytotoxic edema and ischemia of the cells have been already picked up using these retractors. So to say that tubular retractors are safe and minimally damaging to the brain probably is not correct so far as scientific evidence is available. We don't have any scientific evidence of the pressure of the tubular retractors as of now. Now, there's another article of the biomechanical modeling and computer-aided simulation of the brain retraction in neurosurgery. And this experimental observation on canine brain indicates that any brain retraction for 30 minutes did not cause any significant risk of induced damage. And the peak retraction pressure level indicates that intermittent retraction is safer procedure as compared to a continuous retraction for the same extent of time. So in a tubular retractor, you're giving a continuous sort of pressure on the brain, retraction of the brain, rather than intermittent single blade retraction system. There's another article where they have compared two methods of retraction using continuous retraction and intermittent retraction. And here, in this case, they've compared, and they said that continuous retraction, the brain damage appears at a retraction force of 30 grams and increases in proportion to the force used. Corticography shows full recovery after the release of retraction when the retraction force was less than 40 grams. Now, intermittent retraction, whereas can withstand more pressure actually, damage was minimal with retraction force of less than 50 grams, and electrocardiography evidence of recovery was prompt in comparison with continuous retraction. So if you go by these understanding, we have to be cautious about or judicious about using the retraction, specifically if you're using a tubular retractor where you rock the brain, you're putting the brain under constant pressure. A rigid conduit has been claimed to be less harmful as compared with a normal brain retractor. I'm not very sure, so I put these question marks, the exclamation marks here. Constant pressure of the brain would add to ischemic insult apart from compression effect on the surrounding normal parenchyma. And use of pulsatile retractors combined with latex glove lining as we use provides minimal retraction effect and allows the desired exposure needed for the resection. And as I showed, in many of the cases, there's hardly, you just hold the lips or just give a gentle retraction within the tumor margins, and the brain really doesn't fall. As Professor Charlie Tew showed, I'm totally with him, and this is definitely not a big deal actually. Now, the things to watch out again for the juniors, when you're maneuvering your endoscope and instrument, you need to be gentle. There is risk of retraction injury to the normal parenchyma around the port of entry. You have to be careful. Sometimes you are inadvertently not careful about them. Do not hesitate to use a spatula if the endoport or tubular retractor does not allow enough access. So once you've reached there, you better finish your surgery properly. And please don't be shy and don't feel guilty that the microscope should not be used. The microscope should remain as a standby option. There's no ego problem here. You're treating a patient. You're supposed to do the best for the patient. So for the beginners, again, first acquire expertise of endoscopy through workshops and simulations. Gain good exposure to live endoscopic surgery by assisting an expert. Start with simple surface lesion or cystic lesions. Those might be the soft balls to play in cricket. And evaluate outcome and compare with microscopic procedures, and always keep a microscope as standby. And I know Professor Yadav runs a fantastic workshop every 6 months, and he has been great and contributed a lot in this process of teaching the beginners. And of course, certain things for the beginners. Again, I would say the patients which are not ideal for endoscopy to start with are lesions with major calcification. As you saw, I was struggling with that patient with calcified lesion. Highly vascular lesion can really make your field very messy. Giant lesions, be careful, you select the proper trajectory and reach. So you need a lot of understanding and thinking, and you should have the expertise before you go. And if they're solid giant lesions, you have to be very careful. Lesions with wide base, again, can be a problem. And I would never suggest that you go for a meningioma excision, because the principles of meningioma excision are different. I'm talking of the convexity meningiomas. And of course, multi-compartment lesion, you have to be very sure that you can enter into all the compartments. But Professor Tew used the angle scope and showed you how he can go to the other side as well. So, but you need to be expert like him, of course. So to conclude my talk, which is actually summation of all what has been talked earlier, but I have added only the points for the beginners and the new players in the field. Endoscopic excision of brain lesion is safe alternative procedure, provided you know how to do it. Smaller size of craniotomy and narrow corridor of entry is sufficient to allow bimanual manipulation of the tumor with clear visibility of the hidden corners. Endoscope allows better clarity of lesion because of proximity of the scope to the lesion surface. Selected entry through corticectomy usually is a safe surgical corridor under neuronavigation guidance, gives easy access to the lesion. The technique, therefore, is minimally invasive and strictly adheres to the proven microsurgical principles. It needs a learning curve, has to be done in greater number to gain expertise. Proper case selection is important for success. And learning endoscopic tumor excision is the prelude for use of exoscope. I have not used intraventricular lesions, which have used the endoscope to excise, or combination of microscope and endoscope, which is often done if it is needed. So this was overview for the beginners, how to take care of such lesions using pure endoscopic technique. Thank you very much for your patient hearing.
Thank you, sir. Thank you for giving us the elaborative and the beginner's perspective, how to do tumor excision just by an endoscope, and its limitations, how exactly to deal with the deep-seated tumors. So we'd like to keep the discussion till the end, and so hope we elaborate a little bit about the glove stripping technique. And of course, this debate definitely will be on tubular retractor and the topic which you opened with the evidences, the tubular retractor, the alternative, the Professor Yadav definitely would like to speak. We'll keep the discussion live on that, sir. May I invite the next, my co-host to invite the next speaker, please.
Please invite Dr. Sumit.
All right, great. Thank you very much, Dr. Narayan Shankar, Dr. Narayan Swami, and it's my great pleasure to invite the next speaker. He is Dr. Sumit Sinha. He works as a senior neurosurgeon at the Paras Hospital, Gurgaon, and he has got tremendous experience in the endoscopic surgery as well as the minimal invasive brain surgery, besides the other specialties of subspecialties of neurosurgery. So I would invite Dr. Sumit Sinha. Sumit, are you there? He is going to talk about the endoscopic. Oh, you moved on already. Fine, please go ahead, Sumit.
Well, thank you so much, Dr. Sankla, for that opportunity, and NESI, of course, for providing me this to present my humble experience in front of this esteemed audience. And especially Charlie is there, and I hope sincerely that he be here during the next some time, although I know that it's very difficult for him. And the other members of the endoscopic committee that I'm here with, pleased to share my experiences for the next 10-12 minutes of that endoscopy. So I have no financial disclosures. So the task which I've been given is to elaborate about the endoscopic keyhole endoscopic assisted neurosurgery. in deep-seated parenchymal brain lesions, and mostly these are gliomas, which I will be strictly confined to in the next few slides of my talk. So these are the various modes by which we can do the endoscopic and keyhole surgery. The endoport surgery, we all are very well aware about it. Keyhole surgery and endonasal surgery, where only endoscope is used. And to start with the keyhole approach, let me introduce you to this doyen of keyhole approach, who first devised this keyhole approach, Alex Bernatsky. We all know about it. And he was a wonderful innovator and designer and a wonderful surgeon, a human being. I met him, had the pleasure to meet him first in 2010 in Jordan. We attended meetings together, and unfortunately, we lost him 3 years back, and it was a great loss to the Neuroendoscopic Society. He first elaborated the concept of the keyhole approach, in which he defined a keyhole as the minimum craniotomy which is required to access any deep intracranial pathology. And these are the treatises which he has written about, and I'm thoroughly in love with these books. Always go and refer to these books whenever required. And the other one is this hero, the mentor who I idolize, and a very good friend. And I have almost read this book about many times. I mean, and it's a beautiful book. I always recommend this to whosoever is trying to venture out into this keyhole brain surgery. Principles of keyhole, yes. I mean, I would like to tell some of these, and all of these figures have been taken from this book of Charlie. And the keyhole approach offers an inverted funnel view. It's a mobile viewing trajectory with wide and multiple angles of vision, and this is the beauty of this keyhole approach. And the best approach, as elaborated by Charlie, is along the long axis of the tumor, and this is so that we can take all the tumor through the keyhole in that wide-angled vision. So this is one such thalamic tumor operated by me, and this is the post-operative CT scan. The exceptions for this long axis of the tumor are when the tumor is when the tumor is covered by an iliaquid cortex, so that we cannot cross that iliaquid cortex to reach the tumor, so that we have to work perpendicular to that, the long axis of the tumor. And in this here, it is the endoscope which is of significant importance of this. Keyhole approach cannot be used for superficial lesions for obvious reasons, because we cannot look at the back of the door. So that is why it is good for always deep-seated lesions mostly. And the exposure of the brain tissue for a keyhole approach is very, very minimal. So the thermal exposure with the light of the microscope is also very, very less. The brain is very, very less exposed to the light and the heat of the microscope. These are the things which we need in a keyhole surgery in order to have a beautiful exposure, a neuronavigation, helps in placing the keyhole at an accurate location. And of course, brain mapping, omniscient mapping is a wonderful and a must to have tool to plan this keyhole approach. Endoscopic assistance, yes, endoscope is used to visualize, especially around the corners and where there are hidden areas and where we cannot visualize with the straight parallel light of the microscope. Then there comes the endoscope, and I'll be showing you a few examples where the microscopic excision has been done, and then we take in the endoscope to look around the corners in order to excise the remaining tumors. So the combination of the intraop navigation, the brain mapping, and endoscopy has made the keyhole approach feasible and possible. And here are some examples which I will give for the frontal glioma. For example, this was one such tumor. We draw a long axis along the tumor and then project it to the surface. And this is the accurate site of the keyhole which has to be placed. So in this case, this was the incision and this was the site of the craniotomy. This is the post-operative MRI, and it turned out to be a glioma. And this is the endoscopic view where you see that you can see that there is no additional residual amount of the tumor. You see beautiful yellowish texture of the normal brain with petechial oozing of the normal brain. And this is the post-operative follow-up view of the patient. Another similar example of a parietal glioma. You draw the long axis of the tumor, enter into where it touches the surface, and here is the small a small incision in the keyhole craniotomy. Now, during and after the surgical completion of the microscopic completion of the tumor removal, we take in the endoscope, and you see that what a magnified, what a beautiful panoramic view the endoscope offers, and you can take out the tumor tissue in a much confident and complete manner as compared to what in what in a microscopic view is. Callosal gliomas, they are beautiful tumors which can be taken out by, again, a keyhole approach. And this is the long axis principle, a keyhole craniotomy. And this is the postoperative scan, which shows a very minimal amount of residual tumor, if any, after the surgical excision. Thalamic gliomas, again, the long axis rule applied to the thalamic gliomas. And this is the craniotomy. And this is the postoperative scan of this right-sided thalamic glioma. The stereotactic MRI done the day, the same day after the surgery shows a very small residual amount of tumor tissue. And this patient came from outside having a biopsy. And you can see the incision of the biopsy here at one side, and the incision of the resection is almost the same as the incision of the biopsy. Another thalamic glioma, the long axis of the tumor, and you see the complete postoperative excision by the keyhole approach. And this is the endoscopic view. After the removal of the tumor, you see most of the tumor is taken out, and thus the endoscope is a beautiful tool in order to evaluate the completeness of the tumor resection, and which is very important for extending the survival of these patients. And this is the patient immediately after on the same evening after the surgery, intact neurologically. So this is another tumor, another thalamic glioma, which is post-operative complete excision, and this is the patient. Trigonal glioblastoma, any side of the glioma, the same principle applies. The long axis of the tumor, take out the tumor through the keyhole, and this is the post-operative CT scan showing complete tumor removal. Hypothalamic glioma, this is one such hypothalamic glioma, and which was taken out through the transcortical, transventricular, transchoroidal route. And this is a 4 centimeter skin incision, 3 by 2 centimeter craniotomy, and a short video clip, which I would like to show. Image guidance used during the procedure. Frequently, I use image guidance during the procedure, and it helps you a lot in identifying and locating the pathology. This is the transchoroidal route, the arachnoid over the choroidal fissure opened, and image guidance again used to localize the tumor. And this is the tumor, and in the third ventricle cavity, and the CUSA is being used to suck out this tumor tissue. So again, I mean, during the surgery, differentiation has to be made between the normal brain and the tumor tissue. Normal brain jars with the bipolar, and the tumor tissue does not. And this is the endoscopic view after the completion of the third ventricular tumor tissue. And this is the floor of the third ventricle, where you see basilar artery in the perforator sweeping out through this. Immediate post-operative CT scan of this patient, and the 6 months post-operative MRI, you should see complete tumor excision of this. This is the patient after 6 months, and completely intact and with no neurological deficits. Another such similar hematoma tissue. Now, this patient was a child about 14 years of age, and he was suffering from intractable seizures for about 9 years, and to the extent that the seizures were happening 20 to 25 times in a day, and which were hampering his daily activities of living. And this was there was a hematomatous lesion in the hypothalamus, which was this was an epilepsy surgery which was attempted through the intrahemispheric transcallosal intrafornicial approach. So you see, this is the intrafornicial plane after the ostomy, and the plane was developed between the two fornices. The third ventricle was entered. Endoscopic visualization of the lesion, and the tumor decompression again with the CUSA, and differentiation between the normal tissue And since it was a thalamus, hence it was epilepsy surgery, and it was always tried not to be too expensive during the surgical procedure. The attempt was to disconnect the tumor tissue from the rest of the normal tissue. This was the 6 months MRI after the surgery. This patient, this child, sorry. The memory was intact. Oh.
सुबह क्या खाया था नाश्ते में?
नील बगोर सर सुमित सर ने जो सर्जरी की है 12 अगस्त को, तो तब से आज तक इसको कोई सेहत नहीं
So he was completely free of the disabling seizure. So brainstem glioma, another similar glioma which was taken out through a keyhole approach. And you see the beauty of the endoscope is that it can visualize the tumor tissue very well, and so that you can take out the complete tumor excision can be possible with this. After you remove with the microscope, you can take inside the endoscope, and you can have a very wide view, panoramic view of the tumor tissue. And this is a beautiful child 6 months down the surgery after the radiation treatment. Crosses pineal tumors, of course, the keyhole approach, and this is one such tumor where the keyhole craniotomy, the visualization is absolutely the same as compared to what in a conventional craniotomy. There are, of course, certain principles which have to be followed during keyhole approach. And one of them is using a neuronavigation, accurate placement of the keyhole, following the long axis principle and other principles which we told during the initial part of my talk, and endoscopic visualization. Now you see this as endoscope, where you see some of the remnant tumor tissue over here, and you can completely remove this during the surgery and the end of the surgery. Endoscope is a big tool which can help you around in achieving a complete tumor removal. So significantly smaller craniotomy, better cost message, and reduced post-op pain and swelling. This is what the advantage of the keyhole approach is. And of course, a redo surgery if required for high-grade gliomas is easy with less adhesions after a keyhole surgery. Post-surgery radiation, the suture lines are less amenable to gaping because they heal well, because they are linear incisions in most of the cases. So post-radiation healing is also better. So this is what the advantages of keyhole approach are, and that is what is all about. Thank you so much.
Thank you very much, Sumit, for this brilliant presentation. I think we will have the discussion later on, and now let us invite the last speaker of this session, Professor Vijay Parihar. Dr. Parihar works at the Super Specialty Hospital at the Netaji Subhash Chandra Bose Medical College, Jabalpur. He has been associated with the endoscopic brain surgery for a very long time, and he's going to talk about the exoscopic surgery for these tumors in today's session. Dr. Parihar, please share your presentation and start.
Okay. Is my presentation is visible?
Absolutely, yes.
Okay. Good evening, respected seniors, and thank you for giving me the opportunity. And I will keep my talk short in the interest of time, and I've already been talked about so much by the masters for the use of endoscope in especially the brain parenchymal lesions. I keep my talk mainly for the beginners, the role of exoscopes in brain parenchymal lesions. Some of the photographs I have taken from Karl Stoll's website, because we are using the exoscope of that company. but there are so many other exoscopes nowadays available of various company of good quality. So this has been, I think, the crux of the all other speakers' talks, that the comparison and the advantage and limitations of the microscopes and the advantage of these hybrid tools, endoscopes and exoscopes over the microscope. Basically, the visualization, illumination, magnification is the key, and looking around the corner is also important. And one more important aspect when you're doing the such surgery is the ergonomics. During the surgery, you would like to sit comfortably during the surgery and do the surgery rather than the outstretched hand and bend your upper body and neck, especially when you are operating in the posterior fossa or CP angle or pineal region with the help of microscope. And also these exoscope and endoscope helps you in the education training. Your residents are more involved with the surgery, it has been seen, and the documentation of surgery is also very important. The same comparison when you operating through the microscope, especially in the deep-seated target, probably you have to outstretch your hand, which leads to the surgeon's fatigue. And there has been also the bend of the upper body and the neck sometimes leads to the fatigue and tremors and even the suboptimal outcome, rather than if you are operating comfortably by seeing on the monitor, either by using an exoscope or the endoscope. So basically, the optimum ergonomically utilization of these tools, along with the visualization, training, documentation, and ergonomics, is the concept of these kind of exoscope or endoscopic neurosurgery. And these are the various corners, the area of the brain where we are reaching either through the combination of an exoscope or endoscope, or purely through the exoscope. So little bit technical part of the exoscope. It is basically advanced in the rigid lens system, and it provides an high quality images equivalent to the operating microscope. And some of the very important points are it work on the principle of familiar principle what we have been trained through the microscope, because it remains the outside of the body, so you have an ample space between your exoscope and the target area, so you can use your conventional instrument, and it has got the magnification almost equivalent to the microscope, and the focal length variable from 250 millimeter to 650 millimeter. Another advantage, it is a compact, it does not obstruct your working space. And most important, one of the important part is the portability. It is a very small scope, and you can very well utilize if you are working as a freelancer or you are working in different field hospitals. And so it basically based on the visualization, ergonomics, training, education, and documentation concept. And if you compare the properties of the exoscope with compared to the microscope and endoscope, somewhat you find that some of the properties are like microscope, like focal length or magnification, and some of the properties is like endoscope because it work on the telescopic principle, and you have to operate in the by visualizing on the monitor. So basically, it is act as a bridge between for the beginners, those who wants to learn the endoscopic principle or endoneurosurgery. They can gradually shift to the exoscopic training, either over the model or cadaveric, and doing the live surgery, and then understand the principle, and then they can do the endoscopic neurosurgery. Initially thought we used to apply these as exoscope in smaller tumors, simple tumors, but almost since last 7-8 years we are using the exoscope in our department, and almost every part of the brain we have done the surgery, whether it is a ventricular tumors, whether it is a paraventricular parenchymal tumors, whether it is a transcranial skull base like supraorbital keyhole approach, even in the CP angle, vestibular schwannomas, and pineal tumor also we have. And so far, same with the spine also. And then that we are using the exoscope quite frequently in the spine and found it very ergonomically, very useful technique. This is just a short video of setup of an exoscope, one of the case which we have demonstrated in the live workshop, especially for the beginners. The principle of the surgery, the starting of the surgery remains the same. Your incision, whatever you've been planned, remains the same. Just in place of when the time to introduce a microscope, we usually keep the exoscope in place. And as you can see, the exoscope in a mechanical holding arm, and this is a very compact 10 centimeter shaft, robust instrument, and it is a 10 millimeter diameter scope. So it gives a very wide field of view, very good quality, and dual light source has been seen for the better illumination, and it can be attached to the same clamp which we are using for endoscope and any other such instruments, and also the same standard camera system and the light source has been used and hold with this mechanical arm, and there are good pneumatic arms is also available. And just by rotating these mechanical arms, you can angle it to see the cranially, caudally, medially, laterally, and comfortably visualizing the ample of space you can have now by using the same simple instrument of microneurosurgery, suction bipolars, and you can operate with this. So this is just a simple case to demonstrate if somebody wants to learn the surgery through the exoscope. It's a surface tumor, also going down to the deep in the right posterior frontal area, and the small anterior parasagittal craniotomy was done. This is and then the durotomy was done. The purpose of showing this simple case is that you can see the image quality of the exoscope. It is almost equivalent to the microscope. Tumor differentiation, the maneuverability, everything is the same as you are seeing in the microscope, and you are comfortably sitting and looking at the monitor and operating through the small minimal approaches. And the principle remains the same, like debulking of the tumor and then circumferential dissection of the tumor using the same instruments which we have been trained during our residency time. No special kind of instrument is required. And after debulking, you can see just by angulating little bit, you can now see the other side, all other part, and the residual lesion can be taken out. And then again, just by angulating and seeing towards the caudal side, and then you can see and also you can tumor brain intersurface is also interpreted well, as we are seeing in the microscope, and hemostasis and everything can be done nicely, comfortably with this exoscope. No need of so such simple cases can be start with using exoscope, and you can have an hand-eye coordination working in two-dimensional picture. And also, if you comfortable, then use the endoscope and then see your section cavity for any kind of residual lesion or hemostasis checkup. And we can. So this is the small. This is the case. And then another simple case like intracerebral clot can also be practiced through the small craniotomy, and then this is the small craniotomy around 3 centimeter size. Transsulcal incision was given, and it's depend upon you. If you are comfortable, then you can use the retractor, either tubular retractor or a gentle self-retaining retractor. Here I am using the same tubular retractor with the same principle what Yadav sir has taught to us. This is foldable silicone tube, and by inserting through the nasal speculum, and then the clot evacuation was done. This is this, and this angulating the exoscope, checking the residual clot in the, and you can see the ventricle also here. And then after doing the hemostasis, checking the hemostasis with the same instruments, same microsurgical principle, and then that is the after the evacuation of clot, and that is the post-operative scan. So initially we thought that it can be done only for the simple cases, but as we gained the experience, we started using exoscope in various other cases. We just go through the some picture. This is the look at the very simple vessel of large head of the microscope in front of you. It's just a setup of exoscope, small, and you can comfortably visualizing the high quality, high resolution images. And this is the small craniotomy was done. Tubular retractor, sometimes we fix it with the these Lela blade, and that is the post-operative scan. And that is again the, apart from the parenchymal lesion, this is the supraorbital keyhole approach for the cystic craniopharyngioma. And also we got the reasonable safe resection, and the surgery was performed throughout the exoscope. And this is the posterior fossa medulloblastoma. Again, one of the view is very important when you see the excision of lesion and want to see the aqueduct. You have to bend your neck through the microscope quite a lot. Here is just bending the exoscope and seeing on the monitor, you can completely see the good picture of the aqueduct and clearance of the tumor through that. And this is the posterior fossa view. There's image to show that it gives a very panoramic view also. And you can see the lower cranial nerve, 7th, 8th nerve, 5th cranial nerves, Dandy's vein, everything was clearly seen through the exoscope, and you can do the vascular decompression in trigeminal schwannoma. And not only these, we are doing the acoustic surgery also through the exoscope. Like, look at this. This is large right-sided acoustic neuroma. And you can see a good panoramic view. This is the tumor after debulking, separating it from the superior pole and from the brainstem. Then this is again separation from the brainstem. And here you can see through the internal auditory meters, we are clearing the tumor. And this, you can see the 7th, 8th complex here. And that is the after resection of the cavity. And this is the post-operative scan, the total resection of the vestibular schwannoma through the exoscope only. And you can use in the other places, like I just want to show in the Chiari decompression here. Sometimes we use combination of the exoscope with these EasyGo tube, the small incision, and put the EasyGo tube, and then through this EasyGo tube, we visualize through this exoscope and do the surgery. Initially, with the bony work was done through the exoscope. And once the bony was done, we used to change into the pure endoscopy, and then we opened the dura and did the dural decompression. And that is the post-operative scan, which showing a significant reduction in the So initially the 2D exoscope was considered to be some limitation of lack of stereo abscesses and 2D visualization. Now the 3D exoscope has been comes with overcome these limitations. They have a 3D 4K sensor system with higher magnification, better precise focusing, and comparable results was coming to the. We have very limited experience with 3D and performed some surgery in the live workshop, and some training was given in the cadaveric workshop. So the advantage of exoscope, it provides an excellent image quality and illumination depth perception, which are almost equal to the operating microscope. Ergonomics was very good. And if you compare the cost of the advanced microscope, the cost is very less. And still there are limitations are there. Holding arm is still there, the maneuverability of the holding arm. And still we need to assess the use of exoscope in more delicate dissection like vascular surgery, though the papers are coming that people are clipping the aneurysm through the exoscope also. And it is very important that to assess that whether the exoscope per se may affect the outcome of the surgery. But I find it useful too. And more literature now is coming. People are sharing their experience. This is one of the paper in the World Neurosurgery where they have included our series also, which we have been published in 2016 in Asian Journal, which is the first, I think, from India. And they have also commented that there are certain advantages over microscope. And this is the paper which compared the my exoscope through the JAIS or Pentaroscope, and they found it that it is over advantage of in ergonomics and accessibility of surgical field over the microscope, and it has got a potential tool in the other in neurosurgical ornamentarium. So I conclude my talk that it is not a replacement of microscope or endoscope. It can be used as a bridge between the microscope and endoscope, and particularly find to be useful for the beginners who wants to learn the principle of neuroendoscopy. And it is potentially a minimally invasive tool, can be used as a minimal invasive tool, but obviously the more and more studies has been required, and more and more people then share their experience through these kind of exoscope, then only we will able to find out whether it is a really useful tool or not. Thank you very much. I again thanks the organizing committee and Neuroendoscopy Society of India to giving me the chance to organize this webinar. And I also thanks all speakers, Professor Charlie Teo, Professor Yadav sir, Professor Ashish Pathak sir, and Dr. Sumit Sinha sir, to sparing their valuable times, and they have been share their experience in such a difficult topic. And I thanks all the moderators, Sankla sir, Professor Swami sir, and Manas sir, and also the panelist Raju sir, who's keep on motivating me for that, and Dr. Ramesh Tigla sir, who has been kind enough to accept as a moderator, and Dr. Ashish Tandon, who has been a link between me and Professor Teo to make him ready for the talk. Thank you very much.
And we thank you, Vijay, for this excellent presentation, and in fact for organizing the entire program of this webinar this evening. We have now a discussion, and the panelists are there with us. Manas, would you like to introduce the panelists?
Yeah, we have Dr. Subodh, the secretary. He's HOD of neurosurgery at AIT Hospital, Hyderabad, and secretary of the Endoscopic Society of India. And Dr. Ramesh, he's head of the department at Anu Cardiac Neuro Center at Vijayawada, and he's a treasurer of our society. And we have Dr. Anish Tandon, who is head at the Aditya Hospital, Jabalpur. And, so did I make a mistake?
Yes.
So if
is Charles there with us?
Charles there?
Ashish has to wake him up.
No, I'm awake. I'm awake. I'm in bed, so you're not going to see me. I'm going to turn my video off, but I'm here.
All right. So, Charlie, let me start with the first question. I really enjoyed your talk like before. It was a wonderful talk indeed. I was just wondering, when you are removing those large tumors, do you use any? Can you hear me?
Yep, I can hear you.
Yeah. So, after removing the large part of the tumor, when the brain started collapsing and all that, how do you really go after those small nodules which are at the corners of the tumor cavity? Do you use any kind of image guidance or visual aid or something to really locate those tumors before you remove them?
No, I don't. I don't use 5-ALA. I don't use fluorescein, and I don't use intraoperative MRI. I simply use the endoscope. I just, with a lot of experience, you can differentiate normal tissue from abnormal tissue. And I feel sorry for younger neurosurgeons without that experience. But, if you get a few tumors under your belt, you can start differentiating what is normal and what is abnormal. And I think that visualization with the endoscope, good illumination, magnification is probably better than a lot of those other tools that we've unfortunately become dependent on. So no, just pure visualization and no biological markers.
Perfect. Thanks. Subodh.
My question to Sumit. Sumit, when we talk of minimal invasive neurosurgery or minimal access of neurosurgery, what we are hearing today. So it's a very general question. So the endoscope helps, or the minimal access or minimal invasive helps in a better resection of the tumor, or the collateral damage is less? Which is the main point in this? So we are talking of minimal invasive or minimal access?
So it serves both the purposes. I mean, if you ask, what purpose the endoscope is for, so it helps us in attaining access to the deep-seated located tumor, number one. And number two, it helps in accurate and adequate, appropriate visualization of the tumor tissue so that it can be taken out completely. So it is minimal access also, minimal invasive also, and maximally resective also.
Yeah, can I ask Dr. Pathak, can you summarize what is the best technique? Because we had Dr. Teo presenting on without retractor, and you presented on single retractor, and Professor Yadav presenting on a tubular retractor. So, but what is the best, or any all of them have a similar results, irrespective of the technique what we use?
See, it's not a competition of what to use and what not to use, or it's not a company-based sort of, that my product is good and my technique is good. It's the question of your comfort. If you just have a large tumor, we all know even for microscopic procedures, we don't have to really retract for large tumors. You just get into the tumor and the things are there in front of you, and you just have to remove that. And many of these deep-seated lesions in the past, when we didn't have the endoscope, or we didn't have the tubular retractors, we just used two small tiny Lila retractors, which gave almost similar access, like 1.5 or 2 centimeters hole, and we went right up to the thalamus. This has been going on for long. The advantage is that of a single retractor, I would say, is that you can intermittently change the pressure, number one. And if you're operating on an area where you feel the tumor is slightly in the corner, So you just give a very gentle change of your direction, take it out from the area where you're retracting it, and gently give a little bit of retraction on the other quadrant of your sort of circular lesion, whatever you have made, incision wherever you made. And then you use the scope to remove the remaining bit of the tumor using angled scope. So what I mean to say, what I got from the literature, because I was really intrigued that everybody said tubular retract is very good. It doesn't produce damage. It doesn't produce pressure. Lo and behold, you see the pictures. There is a footprint which is quite sort of rigid, like a glazed pathway in the long run. So is it true? Has anybody measured? And those tubular retractors, which are very fancy one and costly one, I believe they look more dangerous to me rather than just use a single simple blade and you enter into a large lesion. The football playground, you don't need all that. For very deep-seated lesion, yes, probably when you are just going for like a 1.5 or 2 centimeter lesion in the thalamus, okay, then you can think of it. Probably when you're going through a non-eloquent area, yes, you can still use the tubular retractors, but it's not in general that you need to use tubular retractors in most of the cases that many of the people profess. It's probably more, I would say, in their mind rather than, the need for it. And if it is a solid tumor, you just retract a little bit of the inner lip of the tumor and the lesion is right in front of you. So it's nothing like, saying that, no, they are not absolutely necessary. But in most of the cases, I feel they probably are superfluous. And you can still manage with minimal retraction and minimal damage without using the tubular retractors, as it is claimed that they are the best. So that question is. And I've already shown in my slides how the different sort of corticography reports and the other changes, ischemic changes, which whatever literature we have, doesn't really support the concept that you constantly sort of retract the brain. Rather, if you give intermittent retractor, and we know for the long run, for other surgeries also, intermittent retraction, pulsatile retraction, all these were good for the brain. So I think that's my thinking. And as I said earlier, when we used to do thalamic lesions, we use very two thin retractors and just use 1.5 centimeter opening to reach the lesions. That was always done.
Perfect. I think you are perfect.
Jump into this discussion. If we look into the history of the retraction, so if we look at Professor Yasargil, he was the one who got a lot into retraction. And then gradually over his own career, he went away. And finally, at the fag end, he sort of used minimal amount of retraction. On the contrary, I see Professor Teo, I have never seen him use a retractor. At the most, very, very rarely, he may hand over maybe once a year a spatula to his assistant to just maybe for a few seconds, that is the rarest of the rare things. But if I say for myself, for tumors, for bleeds, I may not be using the retractor system, but for aneurysms, say for example, when I'm clipping a ACOM aneurysm through a supraorbital approach, and then when I have a gyrus rectus approach and I have to separate the 4 vessels, I have to see that the brain is also retracted. For those few 5, 7, 10 minutes, I do need the help of a retractor. So, I mean, what I'm trying to suggest is we need to keep our options open. So that is what my take is as far as the retractor is concerned. Minimal use of retractor, and really when you absolutely require it. Do I have the liberty to ask one question to Professor Teo?
Yeah, please go ahead.
Okay. So, sir, I have, and we all have watched you. You always use one hand for the scope, and then you are using, and the other for the surgery. Why don't you consider the option of, sort of fixing your endoscope? Because these days the fixed arm also are sort of very versatile. You can really sort of quickly move them as you wish, because then you have 3 hands. At least you have 3 hands. So why haven't you ever considered that?
So the first, it's multifactorial. The first reason is that despite the fact that they are more versatile these days than in the olden days, they are still a bit clunky. And they still have micro movement, and they can still be hit by someone and knocked by someone. First reason. Second reason, the endoscope gives you 2D vision, which is not good for depth. And the way the human brain compensates for that is by movement. In other words, moving the endoscope in and out will give you some depth of field. So that's another good reason. And the third reason is that invariably when you're using the endoscope, you're using it in a confined area, and it's very difficult to get either an assistant or a scope holder to hold it because you're often at a funny angle, you're moving it around quite a bit, and overall I just find it's more easy to use it with a hybrid instrument in my other hand. So 3 good reasons. I'm not against the holder. You can use it if you like, but it just hasn't worked for me. And I've used the most expensive ones, the Mataka, and I've used those very fancy ones, and I still don't like them. So I have erred away from fixed retraction and erred away from my assistant holding the retractor, holding the scope as well.
Ali, what is your view, against or not using the endoport in any of these cases? How do you really come to this conclusion that it can be, it should not be used? The use of endoport.
Is the question to me or someone else?
Yes, to you. Yeah.
Oh, look. So. The first time I saw someone talking about the endoport was Amin Kassam, and he showed these post-operative pictures showing residual tumor where the the tubular retractor had hidden the tumor. In other words, he'd inserted it too far. And I thought, well, surely you're not going to show your worst cases. You're going to show your best cases. So if they were his best cases, they weren't good. And he's a great surgeon, technically a very good surgeon. So I thought that a technically good surgeon showing his best cases still had this inability to assess exactly the tumor that was hidden or underneath the tubular retractor. That was the first reason. The second reason was that I tried using it and I found that it wouldn't allow me to move around and use the natural movement of the brain to look into corners, look at different angles. And thirdly, of course, as the good professor has alluded to, Professor Mahali, is that if you look at the literature is pretty clear that a fixed retraction does cause damage to underlying brain. The first paper, of course, came out by Russell Andrews out of Stanford, and it showed very, very nicely that there was ischemic changes underneath fixed retraction. For those reasons, you just don't need them. Sometimes you need them, like she said. Probably once a year, I might get my assistant to hold the retractor for me, hold some brain that's fallen down because the long axis, there's several different axes. But if you go to the trouble of positioning your patient correctly, then and that is, absolutely perpendicular, the long axis perpendicular, the brain doesn't usually fall in; it falls out, and therefore you don't need to have any sort of fixed retraction. Look, I like the discussion, and I don't want to be 100% dogmatic. I think what Dr. Yadav has done with the a non-fixed tube retractor is good. I think the idea of using a single retractor, not 2 retractors, is good. So if I was going to do it, I'd try and minimize it, but the most minimizing or the most minimal retraction is no retraction at all. So, yeah, that's what we should aspire to, no retractor at all. And Ashish is right. I worked with Yazgul, and Yazgul designed the ladle retractor named after his daughter. He was a great advocate of fixed retraction. I'm telling you, in the 10 years that I was in Little Rock, Arkansas, from when he first came to when I left, he hardly used the retractor at all by the end. So, the natural progression is that if you can get away with it using a retractor, it is better for the patient.
The literature about endoport clearly says that you miss the tumors in the corner. That's already there in the literature. If one really goes to the depth of it, that's why they add a spatula to it to get to that tumor which is on the sides. Number one. And I just am reminded of Professor Mathuria, who was my teacher and then became a colleague. As Dr. Tandon said, he would clip an aneurysm without using a single retractor. So he was a great believer of not using any retractor even for crippling aneurysm. He was so good. So, it definitely is possible if one understands the logistics of how to sort of do those things without retraction. It is possible.
I would like to ask two questions to Professor Yadav, sir. Professor Ashish Pathak, sir.
Yeah.
Firstly, Professor Yadav is a great innovator of this slit in the retractor. Using the micropipette and doing a lot of tissue analysis and EEG recording, I want to ask whether it is for that tubular retractor which you showed, which did not have a slit, or is it for the slit?
See, the slit is, again, I would say, is not really the main thing which saves the brain. Because in that situation, I would say a circular retractor complete without a slit is slightly better. But with the slit, actually, you are damaging the brain more, because if you move the retractor with a slit, you are repeatedly sort of trying to go along the white matter damage. So I would prefer a complete round retractor rather with a slit, because if you're not moving the retractor at all, not even trying to sort of angle it or do anything, then probably a cylindrical retractor would be slightly better. But a slit will always produce some damage to the surrounding parenchyma. The whole idea of discussion here is to avoid any damage, to avoid any ischemia. So we don't know, we don't have evidence to say yes and no to it. So technically, I cannot answer that question, because I don't believe in too much of retraction, as I've already alluded to. And I've been always putting these slides repeatedly with evidence to say that retraction is not absolutely necessary, especially the tubular. There are a lot of things against the tubular retractor, again, because that's a constant pressure. That's a constant pressure. I don't want any constant pressure on the brain. Little bit of retraction just to lead to me, or I want to see the corners, that's fine.
Yeah.
And that's my philosophy. And I strongly believe in that.
Let's have a comment from Professor Yadav if he's around. Just tell us about this, constant pressure because of the tubular retractor.
So, as I said, if you are an expert neurosurgeons, then no retraction is the best. But that comes after so much of experience and obviously position and all that. And in most cases, especially average neurosurgeon require some retractor. So and the other thing is having a retractor and just holding the brain is different. So if you just hold the brain, then obviously and dynamic holding brain does not make any difference. But the tubular retractor which we use is different from what people talk about. The other tubular retractors are so rigid, and so they may produce pressure. The tubular retractor which I use will collapse rather than causing damage to the brain. So this is another difference. And even the slit, I think the brain does not come inside, so there is no harm. And when you put it inside, you rotate it. The other aspect is missing the tumor at the edges. One is that it is a transparent tube. The other basic principle, which I did not discuss in this, is that gradually you go in the depth of the tumor. Keep removing tumor, go at the depth, reduce 8, maybe 4 centimeter tumor into 2 centimeters because of the diameter, and then keep on removing from the depth and come out. So keep watching until you see the superficial part of it. Otherwise, the another disadvantage of tubular retractor or any retractor is that if you remove hematoma or tumor in the beginning, especially if it is very big tumor, and the brain parenchyma falls, if there is a tight brain, and you may miss the depth of a deeper part of the tumor. So go from superficial up to the depth, and do not try to remove the superficial part only. So remove the deeper part first and then gradually come out. These are some of the tricks. The most, the best is by the position and with your two retractor, two suction and a forceps. If you can keep the field open, that is the best. The other option is if you can have a retractor, which is, tubular retractor certainly is better than the spatula. There is no doubt about it, but it has to be the soft. If it is a rigid one and kept for some time, then it is fine. What sir is talking is that he is avoiding the injury because he uses the spatula along with the rubber, I think the gloves, which does not allow the spatula as disadvantage of that spatula is that it may cut through the brain. That has been taken care of, and possibly just as long as you are just holding it, it is all right. But if you say that you are retracting with the spatula for even the smaller period, it will cause damage. This is my
comment one thing.
But obviously, yes.
Can I give a comment, sir?
Yes, please.
Yeah, the tubular retractor, the pressure on the wall will depend on the thickness of the tube, as well as the thickness of the wall, as well as the thickness of the tube. So when you slit it, so when it expands, it reconciles. So the pressure depends on that. So you have to tell us what is the thickness of the tube you use and what's the diameter of the tube, so that it does not damage.
1.5 mm. 1.5 mm is the thickness, so it is
the wall.
Thickness of the tube, and it is silicone, mind you. So you might see that in the beginning it is just 2 rounds. So the brain, if there is too much of pressure, the tube collapses rather than causing damage to the brain.
And what is the diameter of the tube you use, silicone tube?
Initially, I was using 2 centimeter. Now I use 1.5 centimeter also. Gradually.
Because if I understand physics, the lesser the diameter of the tube and lesser the thickness will cause lesser the pressure on the brain.
I don't know. It may be true, sir. I don't know
think
mathematics.
If I just add, because I've gone through the literature quite extensively on this, there's nothing which has measured the changes which is caused, the pressure changes which is caused by different types of tubes. So that's lacking. Secondly, there are some articles which talks of the through MRI of cytotoxic and other edema changes along the footprint of these retractors. There are only experimental studies which definitely prove that a continuous retraction is definitely not going to be a good one. And they have also studied the pressure changes in these animals. So any pressure change above 40 grams of tissue, surrounding tissue is dangerous. Electrocardiographic changes they have sort of studied. So these are there already published. But then again, these are experimental. The turgidity of the human brain, the turgidity of a swollen brain, a turgidity of an infiltrated brain, they're quite different. So we cannot put a hand on the chest and say, well, this is mine is the best and this is the best. But yes, you need to have some access to reach, and depends on whatever way you want to reach and how you reach. And depending on the principles of positioning and other things, you can still avoid. For large lesions, it's very easy, I would say. Only for deep-seated lesions, there can be a little bit of problem. Small lesions, deep-seated, you need to have some support. And that's my feeling with my experience.
So I think
Yeah.
the pressure up to 40 grams by a soft silicone tube is unlikely, although we have not measured. So
it's on the brain, the pressure of the brain, surrounding brain. It's not.
Yeah, but it has to be by the tube, otherwise the tube collapses. So taking some other rigid tubular retractor and extrapolating with the other, the similar tube or a soft tube is not the correct message which should be given. I also agree that one should avoid it, any retractor. This is fine, but if you have to use it, the beginner and other things, to get both your hand free, the soft and tubular retractor is better than the spatula.
No, I have no doubts about your expertise. So we are not going into that sort of extensive debate.
Thank you,
we congratulate you for this device. Yeah.
How much time is left, Manas?
We'll have a last 1-2 question and then we have to close because we have an EC meeting to go.
EC meeting now.
Yeah, one last question.
After Ramesh, and I'll also ask one question after Ramesh.
Yes, okay.
And I will also ask one question.
So, excellent talks from all the speakers, and there's some of the complete keyhole brain surgery nicely. One basic question, like as you all we know that the neurosurgery has evolved from the conventional craniotomy to limited or mini craniotomy to the keyhole craniotomy. I think recently international expert committee on the minimal invasive neurosurgery has defined the size of the craniotomy to label it as keyhole craniotomy is around 2.5 centimeters. So with the available surface localization or intraoperative localization and tumor deculping techniques and adjuvant techniques like endoscope, microscope and exoscopes. So practically nowadays, almost all the brain neurosurgery can be done with the same size of craniotomy, like 2.5 to 3 centimeters. Hardly ever you extend the craniotomy size to some kind of surface lesions like meningioma, all those things. So do we still justify calling this as a keyhole craniotomy, or it is a more of an advertisement tool to label this neurosurgery as a keyhole neurosurgery or keyhole craniotomy? Because most of the younger people, generations, they are going by the advertisements and these kind of literature, nomenclature saying that everybody is a keyhole expert now. Nobody is less than a keyhole neurosurgeon nowadays. If you see their YouTube or Facebook ads and everything. So is it time to consolidate the neurosurgical terminology so that we ease the teaching to the juniors, or at least we percolate the neurosurgical nomenclature simply like it is a standard care of neurosurgery is now to do this kind of craniotomy?
Absolutely right. I think very good question. Is Sumit around?
Can I answer?
Yes.
Yeah, please go ahead. Yeah.
I am disgusted and abhorrently revolted by that comment. Axel Panetsky would be turning in his grave. Now,
I mentioned it in my slide also.
Remember, Axel Panetsky used to always sometimes he would give a talk just 2 slides. Keyhole is a philosophy, not a size. Keyhole is a concept, a philosophy, not a size. If you've got a superficial meningioma that needs an 8 centimeter craniotomy, that is a keyhole craniotomy. Oh my goodness, for anyone to suggest that we try and identify or pick an absolute sort of figure or size to call a keyhole it defies and ignores the entire principle of keyhole surgery.
Absolutely
it's
correct.
all about minimizing. If you're not a good surgeon, if you've got big fat fingers, if you've got poor dexterity, if you can still take out a tumor effectively without hurting the patient, but you need a big craniotomy, that is still a keyhole craniotomy for that surgeon. He's doing the minimal amount of collateral damage to achieve the maximal result. Panetsky would die if he heard anyone trying to define keyhole by a size. That is terrible.
In fact, Excel defined a keyhole craniotomy as the minimum craniotomy required to take out a tumor. So there is no absolute size which a keyhole.
Charlie.
Defined.
Charlie. Hello.
Yes.
Yes, sir. So it's not a debate on the size. Actually, I was trying to say that there's no debate on the principles of the minimal invasive surgery. It's absolutely clear. So what I'm trying to say is that by using the name, many people, they think it is the size of the craniotomy. So that's what I was trying to give, that for the juniors, they should not go by the size of the craniotomy. We simply say that this is the standard care of the neurosurgery nowadays, because the size doesn't matter, because it's 2.5 or 3 centimeters. So there was a consensus statement from the international expert panel that was reported 2 years back. So do we still call that as a keyhole craniotomy? Simply is the minimal invasive neurosurgery, that is simple as that.
No, absolutely. Look, okay, so I understand what you're saying. I understand that a lot of people call themselves keyhole surgeons and they're not.
Exactly.
But to put a size to it, no. You know, I would call a keyhole surgeon someone who thinks about his surgery, who assesses the preoperative images, who doesn't do a standard question mark incision, who is in the operating room looking at the long axis of the lesion, thinking about it, trying to not cut through a particular nerve or an artery to try and minimize dysesthesia of the scalp or devascularization of a flap. That to me is keyhole surgery. Someone who thinks about the craniotomy and doesn't just do a standard craniotomy. So, you know, I don't care how big it is. You know, if he's thought about it, if he's tried to tailor the craniotomy according to the pathology, if he's adopted all the tools that he should be adopting, then that to me is a keyhole surgeon who's practicing keyhole surgery.
Okay, Dr. Ramesh, we can have no control on the people who advertise, because people who do endovascular, they tell they have pinhole surgeons, and people who do radiosurgery, they tell they are no-hole surgeons. So we have no control on what people can advertise. I think we cannot.
See, my question was simple, sir, because this is the standard of care nowadays. See, if somebody is doing a tumor, you need to apply the long axis principle. There's no go in that. So if somebody is not applying that, they doesn't justify it as a neurosurgical principle at all. So these are the standard care of surgery nowadays. So whatever the tumor we removing, we applying all the minimal invasive principles. So there's no question that we are not applying the minimal invasive principles. So should we focus more on these are the practical aspects of the neurosurgery, is we have to apply all the standard principles, what we are discussing every routine case. It's not about the size, it's not about the deep-seated or superficially seated cases. This is the standard neurosurgery now should be practiced by every qualified neurosurgeon. As simple as that.
Perfect.
Can I say something?
Yes,
I see n number of cases of so-called keyhole surgeons nowadays who come back with a huge remnant of the tumor, and then I have to revise them. So the result is very obvious. So those who claim themselves keyhole surgeon themselves have to make a sorry face in front of the patient, and ultimately the patient leaves that surgeon and comes to me. So so that is there. So it's for them to decide whether they want to call a keyhole and land up in their situation. They have made their own mess. So let them learn the hard way. You can't teach somebody.
No, question is not pointing at somebody. What I'm trying to say is, nowadays, with the available technology, the standard of care of neurosurgery is simple. You should do as minimal craniotomy as possible. Use all the possible techniques to remove the complete
Sorry, I beg to differ. They must first learn general principles of neurosurgery. As Charlie said, differentiate between tumor and non-tumor. Those are more important steps.
Exactly, that's what we are telling.
Then after that, they can go on to all that.
Ashish, I think in the interest of time, let us stop this discussion here and then take the last question. Manas?
Yeah, I have a question to Dr. Parihar. You're there, Dr. Parihar? But Parihar, you're there? Is there, Dr. Parihar? Or is there?
Is there or not there?
He's tired. He's tired of discussion now.
You don't see him.
I think he's mute.
No, I'll ask Dr. Yadav then. If you have both exoscope and endoscope in your department, can you tell us which are the cases you would do with an exoscope and which are the cases you will do with an endoscope?
Difficult question. We have both exoscope and.
That's why I asked you that.
So I don't use exoscope at all in any of the cases, except when I find profuse bleeding and using an endoscope. In that case, either I'll use microscope or exoscope. Otherwise, I think Dr. Parihar has said that it is a learning tool, a bridge between endoscope and microscope. The neck pain less and all those things, plus some portability, and you have some learning curve. So he's excellent. He does most cases by exoscope. I use endoscope in all cases.
He's there right now.
Yeah, I've seen Dr. Patak also, sorry, Dr. Ashish Patak also said one thing that probably exoscope is the next step of endoscope. And I've seen, continuously watching webinars.
No. Exoscope is
sorry, I take back my words, but then I've seen a lot of webinars where almost every surgery has been done by exoscope, and combination of exoscope and an endoscope. Professor Sankla was also there in that webinar. That it gives a 3D vision too. So, and then it's quite cheap. Like somebody bought an exoscope for $280 in eBay, and he has done aneurysm clipping to almost everything possible. So, do we call it's the first step to graduate to endoscope, or do we call it as something like the reversal of that?
No. Let us be very clear. The exoscope is a microscope. Full stop. With some advantage. The exoscope does not have the advantage of endoscope. You cannot see around in the corners. It has a linear field of vision. As against the endoscope, you can have view because your eyes are inside. So, as far as angling exoscope, you can angle exoscope, you can angle microscope, but angling, so exoscope is a microscope.
Yeah, Vijay, just unmute yourself, Dr. Parihar. Yeah. So besides the surgeon's comfort, just tell us one more advantage of exoscope.
The advantage another is that it is portable if one is working in the 2-3 hospitals, because the camera systems and all those things are available nowadays. So one can take from one place to another. That is the advantage. And especially beginners, those who are working in various hospitals, does not have such a financial support to they can purchase the exoscope. And obviously 2D vision, working in a 2D vision and hand-eye coordination, which is considered to be initial difficulty in endoscopic surgery, that can be also be overcome by doing the surgery through the exoscope.
Yeah.
Well, obviously it is not a replacement of endoscope. But more and more people are coming with the various kind of surgery through the exoscope. So probably they are claiming that probably it is going to replace microscope in future. But we don't know, because microscope has been developed since last 70 years of refinement. And exoscope comes in almost last decades. But the way the technology and these are coming for visualization technology, we don't know. And another, just a small example, that JICE has also come out with the Kinevo has come out with the part which can be used an exoscope. So
that's right. Yeah.
The acceptance of this kind of technology is there with the people.
But the presently available, two-dimensional exoscope.
One more advantage. Sorry. One more advantage which I heard in one of the talk by Dr. Ortil is that the focal length, focusing he said that it is 5 centimeter or more. I mean, you can see the depth of the field, and another proximal 5 centimeter of field of vision is in focus. So that is a great advantage of exoscope.
Yeah,
But,
can I tell one experience? I did a bypass under exoscope, and the depth of focus, as you told, it's very good. But then it is, the demerit is, even the depth of focus is more, it's 2D. So you don't get advantage of the depth of focus.
Absolutely.
Unless you have a 3D exoscope.
Correct. So if you have if you have a microscopic surgery or doing surgery under microscope or doing surgery with the 2D exoscope, I would definitely choose the microscope. Unless you are talking about 3D exoscope, I don't think the image quality is comparable at all.
No, image is better with exoscope, but then you have to keep on changing the position of exoscope. Now, Synaptics has come with an exoscope where it moves along with your instrument tip. So it's a dynamic focusing. Yeah. But the storage or the Aspler, what they have, they're fixed, and you have to keep on changing, and that takes a lot of time.
Can I very quick comment? I think the exoscope is a transition between a microscope and endoscopic vision, and the practice of operating on a microscope vis-a-vis operating on an endoscope. Because in an exoscope, you are operating looking on a monitor, which is not at all the case with the microscope. So when we graduate from a microscope to an endoscope, exoscope is therefore called as a link between the two, so that you get to train better when you start using an endoscope. So this is how I take it, actually.
Absolutely. All right. Manas, back to you.
Yeah. So I'd like to thank Dr. Parihar for organizing this event, and it was very lively with a lot of discussions, and he had invited all senior speakers. I'd like to thank Professor Charles Theo, Professor Pathak, Professor
Narayan Swami.
Professor Narayan Swami is moderator. This is speaker, and
Professor Yadav.
Professor Yadav, Professor Sumit Sinha. And I'd like to thank the moderators, Dr. Subodh and Dr. Ramesh and Dr. Ashish, and all my co-moderators, Professor Narayan Swami and Professor Suresh Sankla, for keeping the discussion live. And I hope we'll be having a similar session again next month and in the third week. With these few words, I'd like to close the session, and we'll go offline, and we'll have the EC meeting of the society. And I'd like to thank all the audience and Sun Pharma for looking at the logistics of this conference. And an audience who have put their questions in chat box will be answered by the speakers. Technical support from Sun Pharma, I'll request that to keep the chat box open, so that if there are any questions that can be answered by the speakers and the moderators and moderators.
Yeah, is the recording going to be available? Recording will be available on YouTube.
Yes, it will be available.
The recording will be available.
Yeah, initially the thing came that's recorded.
The EC meeting happens in the same link.
Yeah, EC meeting. Can we go offline? Satish?
Just a second, sir.
Okay. Thank you. Thank you. Thank you. Good night.
Thank you.
Satish, can we